My name's Aris. I'm a consultant in fetal medicine. I work in London and in Oxford. And we're behind the screen here with this nice lady who's volunteered today, and a very nice baby. In true tradition, or contrary to tradition, actually, this baby's behaving really well for our live scan today. So the first thing to do when we start a scan is quickly orientate ourselves. So let's say hello, first of all. Hello. And make sure that we know where we are. So the head of the baby is at the top, and that's the bottom of the baby down there. So this baby's breech. And we want to make sure that we know our left from our right. So this is the left side of the screen up here. So the left side of the baby is on this side because that's the left, not because that's where the stomach is. And then what I usually do is run through the anatomy with the parents, and that way I make sure that I don't forget anything. So we start with the head, and you can see the head nicely here. You can see the line which separates the two hemispheres, a little box here which is very important, the cavum septum pellucidum. As we move a little bit further down the head, we can start seeing the appearance of the thalami and the cerebellum. The cisterna magna, which is normal, and of normal size here. And then we take a sagittal view of the head also, of the brain also. If we move this way, you can see here nicely the parallel lines, here of the corpus callosum. And it's just a parasagittal view that I've got here, but you can see that there. And if you have doubts about the presence of the corpus callosum, you can sometimes use color Doppler also to aid in the identification of the, thank you. So if we drop the PRF a little bit, please. And you can see nicely the pericallosal artery, which forms in close approximation with the corpus callosum. So that's an additional little clue, which helps when it's a difficult case. In this case, it's not necessary because it's very obvious. So having finished with the brain, we come down to the face, and you can see the facial features here, looking for the nice confirmation of a normal sized chin, mandible, maxilla, and nasal bone. And you can take all sorts of measurements from the face and from the bones in the face, starting with, of course, the hard markers such as the nasal bone, but also, thank you, some of the other features, for example, looking at the ratio here between the skin overlying the nasal bone and the next line here, which has been recently shown. I don't know if some of you saw it in the White Journal as quite a strong marker for aneuploidy also. Once you've examined the face in the sagittal view, you must make sure that you get a nice axial view. Here we can see the eyes, and we can see a nice normal distance between the eyes. You can see the lenses inside the eye. And if you watch the lenses for any length of time, you'll see the baby looking around. You come down a little bit, you see the nose, and you can see the nostrils and the alveolar ridge. So this is not the palate, this is the alveolar ridge. It's part of the palate, it's part of the hard palate, but it's usually best to report that the alveolar ridge is normal rather than the palate, which includes a soft palate, which is difficult to see at a routine screening scan. And we come down to the lips that you can see very nicely there. So starting from the top of the baby and moving down really, so having examined the head and the brain and the face, we've seen the neck and the skin overlying the neck being normal. I also encourage always everyone to make full use of their facilities. So here, as you can see, I'm going to move into the fetal heart setting, which allows me a better view of the fetal heart. Thank you. And you can see here nicely the 4-chamber view. Actually, it's a little bit narrow there. Thank you. Thanks very much. Thank you. And in the 4-chamber view, you can always make use of color, and what I quite like doing is using a dual screen, which allows me to see the B mode image next to the color image. And that way you can sort of examine the B mode image on the right here for the anatomy, and at the same time, if you freeze at some point and you want to scroll back, you then have both the B mode image and the color image alongside each other. Moving from the 4-chamber view, looking at the size and the shape of the heart, the orientation of the heart, moving upwards, very, very slight movements here to see the left and the right ventricular outflow tracts, and up to the 3-vessel view, tracheal view. And again, always good to get a sagittal view also. Just triangulate really the anatomy, not just by looking at the at one view, like the axial, but always try and get a current view as well of sagittal or coronal, depending on what you're examining. This is an abbreviated scan because of time, so we're going to move on down to the abdomen. You see that we examine the stomach here, and the main structures in the abdomen, the umbilical vein coming in, and gallbladder on that side, on the right side, cord insertion, and the kidneys at the back here. Just zoom in a little bit. Thank you. And then this lady isn't interested in finding out the sex of the baby, so we'll skip that part by moving quickly down to the legs. And again, a sagittal view here of the abdomen, examination of the pelvis. Do you want to look away for a second? Look away now. And it is important to examine the pelvis, even if the parents don't want to know the sex of the baby, just to ensure that the conformation of the structures are normal. And this is also the view where you can ensure that both umbilical arteries are present. And the easiest way to do that is to look for the vesical arteries here. The umbilical arteries are a continuation of those. Down to the legs. And as we all know in medicine, the hip bone connects to the knee bone, and so on. So we see that we have a normal thigh bone, 2 bones in the lower leg, a normal foot with a normal angle, so no evidence of talipes, and a final little turn to see the footprint of the baby. Can we go back to the general OB? Thank you. And then on this tour, we always forget the arms, of course, because what we did, we started with the head and the brain, face, neck, skin, spine, abdomen, GIT, kidneys, and down to the legs. And then you always have to remember to come back up in order to examine the arms and the hands. So taking a systematic approach rather than an opportunistic approach to examining the fetal anatomy, I think is always a good idea. Of course, you can always skip things and come back to them if the baby's in a particularly awkward position, but it is important to have a systematic approach so you remember that you've seen everything, especially in screening. Our life as fetal medicine specialists is quite easy because we don't do that much screening. We often look at specific structures rather than doing screening scans. Is there anything else that the chairs wanted us to point out particularly, or perhaps the audience wanted us to see?
In fact, during one of the sessions yesterday, the topic of how to measure the fetal liver size came up. And so I'd be very interested in knowing what your technique is for measuring the liver.
It's very interesting you should ask that. We've been working for some time at assessing fetal nutritional status. And we gathered quite a lot of volumes of the liver. And I have to tell you that we found it actually very difficult to get an accurate estimation of the liver size, not so much in this view, where you can see quite easily the edge of the liver here in the axial view, but more when you come to the sagittal view, so seeing the inferior margin of the liver, we found not to be a very reproducible measure. You can kind of see it there. But as you move into the third trimester, it often becomes quite difficult. You've got to remember that the abdominal circumference is mostly consistent of liver. And if you compare the studies that have looked at liver size to abdominal circumference, there's quite a close concordance between AC and liver size. So I don't know if by trying to measure the liver itself, we're making our life a little bit unnecessarily complicated. One of the things we always do in our unit at the time of the routine anomaly scan is to do uterine artery Doppler measurements. I'll just quickly point that out. So this is a little bit too much color here. So you can see the uterine artery here aliasing as it moves down. Pulse wave Doppler. And a lot of people say, oh, it's such a complicated measurement and difficult, and it's really not. It takes absolutely no time at all to do. And if you just go to the contralateral side as well, you can see there's one dominant vessel. It's really quite straightforward, and I hope I can convince you that that whole examination of the uterine arteries there didn't take very long at all. Sorry. It takes even less time when you're familiar with your the equipment that you're using.
Could you show us the nasal bone, and if position is good, the prenasal thickness, as this is the topic of one of the next speakers?
So here you can see the profile of the baby very nicely. Make sure that the focus is in the right place in order for you to maximize your view. Some machines have little tricks, like this one, for example, has this special button called the clarify button, so it enhances a region of the anatomy. And I don't know exactly what Katya's method is for measuring the prenasal thickness, but you can see here not just the nasal bone, thank you, not just the nasal bone here, which I can point out, but also the skin overlying the nasal bone, which is this little area here. And you can compare that thickness to a line between, can you see I'm drawing a line here from the tip of the chin, the tip of the maxilla, and this line goes up like that. And you can use that to compare the skin overlying the nasal bone. And usually what happens is that the ratio of this line here from there to there is longer than the line from there to the end of the nasal bone. There's 2 or 3 papers now in the literature suggesting this is quite a measurement that seems to be quite stable throughout gestation and quite a strong marker for trisomy 21.
That's a very nice demonstration of an examination. We take one question from the floor. If anybody has a question from the floor they would like to be shown. Thank you very much for that.
Thank you.
Thank you very much. That was an excellent demonstration. Thank you.